Three, two, one. We are live now, sir.
The Intas team, you can start.
Yes, sir. Thank you so much, sir. So, good evening, everyone, and welcome to the fifth episode of Blood, the Life Savior. I'm Shweta Chandrakar from Intas Pharmaceuticals, and we are delighted to have you join us once again on this unique academic journey where we explore the many phases of hematological disorder, some rare, some deceptive, and all of them clinically important. Today's session is hosted in collaboration with the esteemed Rajiv Gandhi Cancer Institute and Research Center, New Delhi, a name resonating with excellence in hematology and oncology. We sincerely thank the entire team at RGCARI for partnering with us and supporting this educational initiative. The topic of today's episode is as intergrowing as it is rare. Hide no more. The Moscow trope, hereditary pseudohemophilia. This condition reminds us how easily some bleeding disorders can be misdiagnosed and even missed altogether, and highlights the clinical need for deeper awareness and diagnostic sharpness. Before we move into the case, we'd like to acknowledge and thank you, our respected course directors, Dr. Biju George sir and Dr. Joseph John sir, for their visionary leadership and continuous support, commitment to advancing hematological education across India. Dr. Biju George sir is a professor in the Department of Clinical Hematology at CMC Vellore. He is a clinician scientist with over 17 years of experience. He has over 296 publications to his name and is known for pioneering several transplant protocols, including the national standard for aplastic anemia. And Dr. M. Joseph John, sir, he is a professor and head of clinical hematology at CMC Ludhiana, who has been instrumental in establishing comprehensive hematology and transplant services in North India. His leadership has earned national awards and helped to shape innovative clinical practices, including the DM program in clinical hematology. We are privileged to have such a visionary experts guiding this series. And with that, I now hand over the session to Biju George sir and Dr. M. Joseph John sir to take us forward. Over to you, sir.
Yeah, thank you so much. Welcome everybody to this webinar. Over the last 5 months, we have been using cases and case discussions to discuss about various aspects of hematology. We started this in January 2025, and this is the fifth edition of that. And we hope to keep going for a total period of 24 months. That's 2 years. And we hope that within that period, we are able to sort of discuss all various aspects of hematology. Today, we have our friends and colleagues from Rajiv Gandhi Cancer Institute, who's going to be talking about, looks very intriguing, the topic being Hide No More, the Masquerade. I would like to just introduce Dr. Dinesh Burani, who's the director and head of the Rajiv Gandhi Cancer Institute. He's been an old friend of mine, training in CMC Vellore and then going on to Rajiv Gandhi Cancer Institute and then establishing the transplant program and leading the transplant program there. I will hand it now over to Dr. Dinesh to take this session forward.
Thanks, Biju. Thanks, Intas, for inviting us, our team. I also don't know hide the more. I don't know the sense of what hide no more, and so my team has done this topic which they have written it. I'll request Saravanan to present the case. Shall we start with the case?
Yes, sir.
Sure. Right.
Can I start sharing my screen? A very good evening to all. Yeah, thank you for the opportunity, sir. I'm grateful to present this case of a 73-year-old gentleman in this fifth episode of Blood Series of India. I'd like to tell the story of a 73-year-old gentleman with no prior addictions and comorbidities who has presented to us and has given his history in the form of a few episodes that has happened over in his life. In 2013, he underwent a retropubic prostatectomy under spinal anesthesia and got discharged at post-operative day 3. And the procedure, according to him, was uneventful. Coming to the next episode that has happened over in his life was in July 2023. He had an episode of profuse, sudden, spontaneous anterior epistaxis requiring ICU admission and transfusion support, which required 4 units of Paxil transfusion and 6 units of FFP transfusion. And it required an IPD stay of 4 days during that episode. However, there were no records of coagulation profile available during that time. And gliding over, his next episode was in October 2023, where he had a profuse surgical site bleeding post an RTA, resulting in left bicondylar tibial fracture, which required transfusion of 6 units of Paxils and 8 units of FFP, and required SICU stay post-plating. However, according to the history he recalled, his pre-op coagulation profile was reported normal by his doctors even during the pre-anesthetic workup. Gliding through his next event that has happened was in May 2024, where he was feeling weakness for about 15 to 20 days, went to a local physician who found a microcytic anemia of hemoglobin 10.2 gram per deciliter. On evaluation, there was iron deficiency, and he was given IV iron followed by oral iron supplementation, which resulted in improvement of his hemoglobin. After that, his next period of time was uneventful, and in July 2024, the planned explantation of the left tibial plate was done, but post-operatively, there was profuse bleeding resulting in hemorrhagic shock and ICU admission during that period. After that, he went home, and the next quite a few months was uneventful. And the next episode of bleeding happened in March 2025, where he had a spontaneous intractable anterior epistaxis, which was a difficult to control bleed, according to his ENT surgeon, forcing him to go for sphenopalatine artery ligation. He also advised the patient to go consult a hematologist, considering his bleeding episodes that has happened. Thereafter, he was referred and came to us for further evaluation. At this point, we have asked him a thorough detailed history where he recalled his episodes of bleeding. Apart from that, he was unable to tell no other hemostatic challenge, and there was no prior therapy with antiplatelets or anticoagulants, no treatment with any alternative medications, and his examination showed a pulse of 100 per minute, and BP was 136 by 80 millimeters of mercury, and there was pallor and chylomicas were noted. Otherwise, there was no organomegaly, no soft tissues masses were palpable, and no palpable bony tenderness was found. His ISTH bleeding score was 8 points, after which we went in for further evaluation. His hemogram showed hemoglobin of 8.2 gram per deciliter with a normocytic anemia with MCV of 98 femtoliters, whereas the other 2 lineages were normal. Peripheral smear showed anisopoikilocytosis with mild hypochromia with normocytic anemia with rouleau formation. Otherwise, his biochemical investigations, LFT showed a total protein of 7.4, out of which globulins were 4 and albumin was 3.4 with slight AG reversal. His creatinine was 0.9, His ionized calcium was 1.2. In an elderly male with normocytic anemia with Roulet formation with slight AG reversal, also forced us to work for myeloma, where we did the LDH, which was 187 within normal limits. Beta 2 microglobulin was 2,994 milligram per liter. Upon further evaluation, serum protein electrophoresis was done, which showed an M band of 2.1 gram per deciliter, which was of IgG kappa subtype on immunofixation electrophoresis. The SFLC assay showed kappa light chains of 207 milligram per liter, lambda light chains of 18 milligram per liter, and the ratio was 11.5. We went ahead with the bone marrow evaluation. The aspirate showed 18% plasma cells, which also had abnormal plasma cells, and the bone marrow biopsy showed increase in plasma cells with upon IHC with CD138 showed 10 to 15% with kappa restriction. The PAS and Congo red stains were negative. The fish-based testing for myeloma showed a TP53 deletion, which was identified in 72% of the plasma cells tested. The whole body 18-FDG PET scan showed no evidence of any metabolically active disease in the body. At this point of time, our working diagnosis was high intermediate risk IgG kappa smoldering myeloma because of the IMWG risk stratification score amounting to 9 points. So at this point, we also went ahead and worked up with coagulation, which is the other side of the coin, which showed the coagulation workup of this patient. Showed blood grouping of O positive with hemogram 9.2 gram per deciliter hemoglobin with total counts 5,790 and platelets 1,88,000. The prothrombin time was 10.9 seconds, which was within normal limits. Activated partial thromboplastin time was 46.5 seconds, which was prolonged. The thrombin time was 15.3 seconds, which was within normal limits. And fibrinogen was by class assay was 483 milligram per deciliter. The 5 molar urea clot solubility test was normal. We also did a factor level assay, which showed factor 10 level within normal limits. Factor 8 was reduced slightly with 43.3%, and the von Willebrand factor antigen levels was 27%, 27 units per deciliter. The factor 9 was 50 within normal limits, causing us the probable localization at this point of time was intrinsic pathway defect. The mixing study showed a PT ratio of 1.01, APTT ratio of 3.35, which is elevated, and the APTT mix ratio was 1.24. The Rosner index was 7%, which is low, suggesting the possible mechanism to be factor deficiency like activity. We went ahead with platelet aggregometry, which is by PFA 100, which showed ADP 75% normal, epinephrine normal, collagen normal, arachidonic acid was 75% and normal, whereas ristocitin by 1.25 milligram per ml was reduced, whereas low dose ristocitin 0.25 milligram per ml was within normal limits, suggesting the possible functional defect being defective interaction of von Willebrand factor with platelets. So our trajectory has forged like in the movie Sherlock Holmes, where when we eliminate the impossible, whatever remains, however improbable, must be the truth. The trajectory of this patient's events has led us to a roadway which was away from the normal world of fibrin into the realms of paraprotein. With intrinsic pathway defect, factor deficiency like activity, defective interaction of von Willebrand factor with platelets in the background of acquired paraproteinemia made us suggest this could be a high-risk smoldering myeloma with acquired von Willebrand disease, suggesting us to look upon whether the monoclonal gammopathy that was pre-existent all through the trajectory during the various points of time, starting from the index bleed, that is in July 2023, TB, whether and left tibial fracture, followed by tibial plate explantation related bleed, followed by another severe epistaxis causing resulting in sphenopalatine artery ligation in March 2025, making us wonder whether all before everything that has started, the pre-existing monoclonal gammopathy was of any clinical significance. So with these events and the summarization, we went ahead with the working syndromic diagnosis of high intermediate risk category IgG kappa smoldering multiple myeloma with bleeding phenotype being as acquired von Willebrand syndrome as plausible mechanism. Whether the underlying pathophysiology has started because of the monoclonal gammopathy, which was of clinical significance, like in the like phenotype that was existing. So coming to the current point of time, the patient at present stands was with us in regular 3-month follow-up at RGCI. However, at his follow-ups, he did not give any history of overt mucosal bleeds. With the suggested workup that in the follow-up, yearly PET-CT that was undergone by him showed multiple skeletal lytic lesions in the axial and appendicular skeleton in the whole body scan, thus resulting in progression of the smoldering myeloma over the period of time into multiple myeloma with RISS2 risk category with acquired von Willebrand disease as the bleeding phenotype. So we offered him the therapy of quadruple based therapy with daratumumab, bortezomib, lenalidomide, and dexamethasone, along with bisphosphonates. Now I would like to hand over to my consultant moderator, Dr. Akanksha, to take over the discussion.
Good evening, sir. While we are primarily a center that treats malignant cases, this case was particularly of fascination to us, and we chose this particular title. It's because for elderly bleeds are often overlooked. We never look for any serious causes on late occurring elderly bleeds, and often the diagnosis of a malignant disorder takes over the further management of the patient. We also feel that acquired von Willebrand disease is a diagnosis that is often underdiagnosed. How this should be managed, at least in the scenario of a monoclonal gammopathy of clinical significance, there's no clear-cut guideline. That is another area that we would like to explore in this particular teaching session. We were lucky that over a period of time of follow-up, the patient actually progressed. So we had no other choice, clear-cut choice, as to put him on quadruplet therapy. But I wanted to share with my colleagues and my esteemed teachers if they would treat this patient at the point where he was in a monoclonal gammopathy stage, if they would put him on therapy or just treat his symptoms as per his bleeding type.
So I can start. Yeah. So if you go back into the history, we've had a patient who's had about 3 or 4 episodes of significant bleeding, with some of it spontaneous, some of it on the background of procedure. So we would definitely have considered, even if it was at a smoldering myeloma level, which I think was the original one, we would have definitely gone ahead and treated it. Because in this situation, unless you treat the primary problem, the bleeding phenotype is not going to improve. And so if you have a patient who's symptomatic for bleeding, and if you look actually over a period of 2 years, has had at least 4 episodes of significant bleeding, many of it actually resulting even in shock, yes, we would have probably considered in this patient whether we would have treated early. Definitely.
Sir, when we researched for literature, we found that the probable therapy that they would be giving these patients would be high dose immunoglobulin therapy. We were wondering if that would be the practice that you would also adopt, or would you straight away treat myeloma per se?
We would see, if you look now, the whole concept in smoldering myeloma is actually changing.
Yes.
From a time of saying that we would just observe and wait till the patient became multiple myeloma and then treating. Now the concept has changed. Actually, even the smoldering myeloma has now got what we call as a high risk and a low risk smoldering myeloma. And this patient with a TP53 mutation definitely would fall into a high risk. And in the presence of symptoms, we would definitely treat with anti-myeloma therapy.
Sir, additionally, I wanted to know what would you have done initially in the workup of this patient? What would be
I think the
what
workup
would
is
be
exactly
your
what you would have done. No,
what would be
I mean,
your
I would have,
approach?
yeah, I would say it's exactly what you people have done. Because you've got a patient with myeloma, you've got unexplained clinically severe phenotype because the ISTH score is 8 points, which is quite significant. So we need to get down to the bottom of it. So our pathway would have been again to look at the PT, APTT, the thrombin time, and the platelet count. And then the commonest situation here would be a factor 10 deficiency. That is probably the commonest. But once we find that you have an APTT which is abnormal and it's correcting, which means there are no inhibitors, the PT was normal, your thrombin time and fibrinogen was okay, we would have done a factor assay to look and see which factors were there. And of course, when we find a factor 8 which is low but not significantly low, you always need to rule out. So it's like a mild hemophilia. You definitely need to rule out von Willebrand's disease. And definitely there is association of both MGUS, smoldering myeloma, and multiple myeloma with acquired von Willebrand's disease.
So we were also wondering, I'm sorry to interject you, sir.
So I just said all this evaluation would have only occurred because he's got a bleeding phenotype, which is not explained by the myeloma.
Yes, sir. I was also wondering, like, since our patient also has had a significant bleeding phenotype, a lot of myeloma patients may have type 1 deficiency, type 1 kind of acquired von Willebrand deficiency, where most of the screening tests would be normal. Would you suggest in such patients in myeloma patients we should have a high index of suspicion and do the von Willebrand antigen level per se? Would that be suggestive? Or we should go by the clinical scenario on individual basis?
I mean, we wouldn't be testing everybody, but we would definitely be testing anybody who's got a bleeding phenotype which is disproportionate to what they have. So, for example, if you have a myeloma who presented with severe thrombocytopenia, and if you felt that the bleeding phenotype is related to severe thrombocytopenia, then you may not necessarily evaluate for everything else. Of course, we would do a PT, APTT only if that comes abnormal, you would do it. But here, this kind of patient where there are 3 or 4 significant bleeding episodes which are not typical thrombocytopenic episodes. In addition, thrombocytopenia is not there. We definitely would have gone forward in terms of testing.
Okay, sir. Sir, I would now pass over the mic to my colleague, Dr. Archit. He will be taking us through the treatment and pathogenesis of smoldering multiple myeloma.
Good evening to all teachers, and thank you, Vijay sir, for the guidance. At times, the coagulation workup is available in limited status in other cancer-only hospitals. So this was a challenging situation for us, and senior diagnosticians from Sir Gangaram Hospital were very helpful in allowing us to do this work. So I'll start with the discussion. Well, discussion will focus on the stages of myeloma with regards to SMM, the concept of monoclonal gammopathy of clinical significance, hemostasis altered in plasma cell disorders, possible bleeding phenotypes, a certain overview of acquired von Willebrand syndrome, workup, prognostic and therapeutic considerations. So, as we know about the myeloma, like it's a proper in stage wherein the disease is initiated by the triploid changes, followed by the SMM getting some monosomies, and then the multiple myeloma cells acquiring.
Is a
recurring
voice
genetic-
breaking? Is a voice breaking, or what's happening? Is it some problem with your voice? Just see how we go. Thank you.
Am I clear, sir, now?
You're clear now.
Okay, thank you, sir. So, we know the myeloma passes through stages. They may not be watertight compartments, but as a proof of concept, they go through the changes of MGUS having hyperdiploidy, followed by the stages of SMM getting secondary genetic events in form of monosomies, and overt multiple myelomas having recurrent mutations and behaving like proper malignant phenotypes. So, as we know, the diagnostic criteria, they are laid by the IMWG group, and they try to classify the patients in terms of MGUS SMM on basis of the M band concentration, the bone marrow plasma cells, and depending upon the CRAB events. So this was this was identified by the phenomenal study which was done by Professor Robert Kyle and his group, and therefore we have such a clear-cut picture of the study done over a period of 40 years. However, the common CRAB markers are known, but still it is important to consider that there are certain events which are not myeloma defining, however, may still require treatment. So the BJH guidelines released in 2021 told us that symptomatic hyperviscosity, coexisting severe amyloidosis, recurrent bacterial infections, and an osteoporosis with a low Z score could also be probable events which can allow for initiating treatment of myeloma. So the gamut of SMM has undergone an evolution of understanding, with Professor Philip Grape and Dr. Robert Kyle coining the term SMM to the first consensus statement to identifying the highs and lows of the FLC ratios, and then identification of the other biomarkers like MRI lesions, the SFLC ratio greater than 100, the 60% plasma score, and the final event was the addition of slim CRAB criteria to identify the subcohort within the cohort of SMM who may probably progress. So there has been a beautiful editorial in the Hematologist magazine of the ASH, which is written by Professor Ish Kumar and Professor Rajkumar. It says that the philosophy of SMM can fall into the three subtypes. As is shown in the figure A, it can just be like a traffic signal. Green, yellow, red in the reverse. The green is MGUS, yellow is SMM, and the red is myeloma. This means they are totally three different states, and they have possibly no relation to each other. The paradigm B is that MGUS is a state with relatively no malignant cells, SMM is a state wherein there are some malignant cells, and myeloma is a state wherein everything is malignant. And the third paradigm is that the SMM is a intermediate state and is a mixed bag of people who are having MGUS and people who are having myeloma, which is just not overt and being a covert person like a sleeper cell. So the most important trajectory or the most important distinguishing feature for us to understand in patients who are now presenting to us with SMM is whether they will follow a slow increase in trajectory or whether there will be a rapid increase in trajectory and they will behave as malignant myeloma proper. Therefore, an approach to SMM goes through the process of a routine workup, bone marrow, SFLC, routine evaluation, and thereby risk stratification, so as to understand whether it is in the low intermediate risk or high risk. Because in the high risk, there is some evidence to suggest that therapies with lenalidomide, dexamethasone can help prevent the occurrence of myeloma and can delay the progression. So risk stratification of SMM has been also a sequential work in progress because of groups working over many years. The initial risk stratification was predominantly anatomical and physiological. Physiological involving immunoparesis, anatomical involving aberrant plasma cells, and therefore it was also able to substratify SMM into three stages with distinct time to progression. What followed next was the Mayo score 20-20-20, which is easier to remember, because it contains bone marrow PCs, M protein more than 2 grams per deciliter, and FLC ratio, which also gave a very good 2-year and 5-year progression-free differentiation in order for us to prognosticate patients. Building upon these two and making it a comprehensive, the IMWG group has come up with an even detailed substratification based on a multivariate analysis, which now further delineates the prognosis and allows us to prognosticate the patients and thereby assume a high-risk phenotype for allowing chemotherapy early. Now, there are some ongoing trials which have been mentioned in paper by Professor Mori Guts. I want you to look only at the trial number 1, 2, and 7. So the trial number 1 is the recent Aquila trial, which has been published. There are subtle many caveats to the study published recently in the FDA ODAC study. However, for the sake of discussion, let's now assume that it lowers the risk of progression to daratumumab to 51% and is statistically significant. There are many caveats though. The E-PRISM study, which again sees disease progression at 2 years, the results have been established on the clinical trial website. However, the p-value is not established. And the last study, the DITER SMM study, is the study which is being planned by the famed Eastern Cooperative Oncology Group. And the primary endpoint is to see a OS benefit. However, the results of this study will only be available after 13 to 15 years. So till the meantime, the field is going to be a dynamic and evolving. So now coming to monoclonal gammopathy clinical significance, we are all connected in the great circle of life and nothing more than our blood to prove that, wherein everything and everything is connected. MGCS is a clinico-pathological entity. It is evidence of a paraneoplastic manifestation. The clone may not be dominant, the disease bulk may be low, and symptoms should be attributed to the monoclonal gammopathy after the common causes have been ruled out. As it is a
And do you want to keep the cut down this discussion anytime so we can have more time for the discussion? I'm fine. Biju?
No, Dinesh, we got time, so that's
Okay.
not a problem.
So you run the show how you do it. Okay, thanks.
Okay, thank you, sir. Being a paraneoplastic process, it will always be a multi-system disorder. So in this point of time, we have to behave like rheumatologist, neurologist, endocrinologist, and we cannot remain an isolated field. And therefore, it will be a differential diagnosis for patients with MGUS with other unexplained symptoms. As Vijay sir told, like even with MGUS with such a bleeding phenotype, this could have been considered as MGCS. And the most famous and most primal recognized manifestation of MGCS, as recognized by Professor Lung at Mayo Clinic, was MGRS, which is now being here. Having said that, there is a large gamut of neurological, renal, dermatological, and other conditions which can present as monoclonal gammopathies, and there is a lot of overlap between various specialties. And this is a beautiful review done by Professor Dispensary and her group, which shows that it is a clinico-pathological entity and requires tissue diagnosis up to the core. So therefore now the things are becoming much more difficult even in neurology in myeloma, previously which was related to neuropathy, drug-related neuropathy, compression-related myelopathy, or osteoporotic fracture. Now a CIDP patient having an M-band will be eventually a long case even in hematology DMX. So MGCS and hematology. So how can something which is circulating in blood stay away from the blood? It is like a child staying away from the mother. So we do have certain anecdotal reports. It's not been actively accepted, but the field is moving ahead in that direction. So we have monoclonal gammopathy of consumptive significance, thrombotic with thrombocytopenic. We have monoclonal gammopathy of clinical significance having a bleeding phenotype. So now I'll just take you across this case. So this case is published by Professor Padmanabhan from Mayo Clinic. So in the lab, they are working on what was causing thrombosis in this person. He was a 64-year-old gentleman having recurrent arterial and venous thrombosis. The thrombus localization was in the large and small vessel. The thrombi were even occurring on anticoagulation. On review of records, there was monoclonal gammopathy of undetermined significance with no monoclonal events. As you can see in the figure A of the graph, there is a consistent increase in the IgG corresponding with the reduction of platelets and with the occurrence of thrombi. So this is something similar to heparin-induced thrombocytopenia, something similar to COVID vaccine-induced thrombocytopenia, which temporally correlates with thrombi and fibrin drop. And the corresponding person who was suffering with this had an anti-PF4. Now a sophisticated analysis was done. I want you to see in figure B and C that an ELISA optical density was done for the PF4 antibody and the WIT related assay, wherein the concentration was less than that of HIT, akin to near plasma. as shown in the figure D, it shows the activation of platelets when they were exposed to the PF4 elute from the patient versus a normal PBS used in labs as a diluent, which had a significant platelet activation. And after an extensive analysis, it was identified that this was a IgG lambda phenotype. Now, something which is important for us to remember is like heparin-induced thrombocytopenia will also have anti-PF4, which can be activated alone. However, Professor Padmanabhan's group has categorically told that MGCS to cause a thrombotic phenotype, the anti-PF4 has to be in combination with multiple polyanionic antibodies, and these antibodies are actually negatively charged and they thereby drive the pathological process. Similarly, this is a case report which has been published demonstrating the antithrombin antibody. This was a 64-year-old gentleman who had a sudden onset psoas hematoma. As you can see in the figure A, the APTT is elevated, PT is normal, TT is elevated. So it is possibly a defect at the level of prothrombin to thrombin conversion along with an elevated APTT. Below you can see the thrombin generation and thrombin mixing studies. As we are increasing the dilution, the elevated thrombin time starts reducing. It means the inhibition is occurring at a tighter effect. And in the figure B is shown the thrombin generation test, which is a global assay for hemostasis, which is illustrating similar concept that as you increase the dilution, the thrombin generation increases and it is essentially non-existent at the base. Given the extensive workup they have carried out, the C1 and C2 are normal. QC is the quality control. The right-sided figures of IgG, antithrombin antibody, and plasma represent the IgG phenotype, the antithrombin antibody which has been isolated from the plasma, and the normal plasma electrophoresis. So they have causatively proven that this was the in vitro effect. Now to see the in vivo effect, they went a step ahead. They did confocal microscopy and intravitreal imaging, wherein they merged platelets, fibrin, and saw the active phase of coagulation through a process of time 30 minutes, 60 minutes, 90 minutes. As you can see in the left, the platelets, fibrin merge and they form a clot. However, in the right, there is, with the patient's IgG, there is no clot formation. The graph on the right also shows the same. With the patient's IgG, the platelet aggregation reduces and the fibrin formation reduces. So this was again a monoclonal gammopathy of true hemorrhagic significance. So there are certain factors affecting plasma hemostasis in both disorders. It's like a seesaw. In some patients, thromboembolism is predominant. That is why we calculate the saved score and we start prophylactic, usually ecosprin or in certain cases anticoagulation. While certain group of patients can have a bleeding phenotype. As we know in the causative triad, there is always a role of agent, host, and environment. So similarly, the factors will also be disease specific, patient specific, and drug specific, which we usually practice in our day-to-day practice. So this is a latest review published in the Journal of Frontiers of Hematology, wherein now they are studying the causes of thrombocytopenia in patients of multiple myeloma. And as is true is anything in hematology, everything from the initiation to the terminal phase can cause disease. So there is a multifactorial inhibition right from the level of a common myeloid progenitor, common erythroid and megakaryocytic progenitor to the ultimate pro-platelet formation, which suggests an evolving role of bone marrow microenvironment in virtually all disorders with hematology. So to think about therapy-related bleeding risk in a clinical scenario, it can either be chemotherapy-induced immunosuppression, it can be thrombotic and microangiopathy, which can be related to carfilzomib, it can be an alkylating agent-related mitochondrial dysfunction, lenalidomide-related platelet dysfunction, our common NSAIDs, sepsis, and a relatively non-malignant type of thrombocytopenia is cyclical thrombocytopenia, which occurs on day 7 and recovers by day 13, which tends to occur most commonly with bortezomib. However, now there are certain disease-related bleeding risks which need to be addressed directly at the diagnosis. Is the disease burden high? Is the isotype IgA? Are there mechanical changes of raccoon eyes? And is there a high viscosity demonstrated by retinal hemorrhages? Are there other paraneoplastic manifestations like acquired von Willebrand disease, elevated APTT with reduced factor rate? Is there a heparin-like anticoagulant? And there are then certain mechanical molecular factors which can be related to cytokines, and abnormal platelet function per se can also be there in multiple myeloma. Acquired coagulation abnormalities, as is important, they can be incidental when you screen someone, or they can be symptomatic like the gentleman who came to us. Usually they will have abnormal coagulation tests. There may be some partial correction or no correction as per Rosner's index, and they can act at varied levels depending upon what type of mechanism they are having. So need to understand the VWF, which is the core member. So 1 Willebrand factor is, we just say it as 1 Willebrand factor, but it is really involves a lot of steps, like from generation of monomer to the packing in the pallid Weibel granules of the platelets, and then which also further undergoes modification by enzymes of ADAMTS13 and plasmin. The regulation of 1 Willebrand factor goes through macrophage, hepatocyte, and splenic endothelial cell. As we know, it's a very huge protein, and various other ligands can interact with it. Being a huge protein and having multiple interacts, it has disease pathogenesis roles in multiple diseases, as hemostatic effects in thrombotic disorders through non-hemostatic functions. Like Professor Epan had a study at CMC Vellore, wherein he had a hypothesis like hyperactivated 1 Willebrand syndrome is actually responsible for the acute liver failure, and therefore plasma exchange helps, and which was eventually published as a case series. So now if we have to understand how 1 Willebrand factor and the Newton are related, they are not related, but they are still related. So there are two types of fluids. One is a Newtonian fluid, one is a non-Newtonian fluid. So a Newtonian fluid is like water. It will be uniform throughout. Its viscosity will be same, and therefore the resistance may not vary across different flow rates. However, the non-Newtonian fluids are like lava, blood, toothpaste, whipped cream. So we know, like the toothpaste, when it is inside the inside the canister, it will be okay. But when you press it, it flows well. So similarly, it's true for the blood. There is very little resistance when it flows in the large arteries, but when it flows in the arterioles, there is a massive resistance. So this non-Newtonian mechanics plays a very important role of shear activation. So as we can see in this graph, as the viscosity and the shear rate will change. The greater the shear rate, greater the interaction, greater will be the activation of 1 Willebrand factor. So now we need to understand the smallest vessels which contribute to blood pressure is also the arterioles, and as they contribute to blood pressure, the shear interaction with the arterioles with the 1 Willebrand factor and platelets is also the highest. Therefore, in these arterioles, when we do not have an active 1 Willebrand factor, the platelets cannot get activated, the capillary fragility results, and therefore these patients bleed at those sites of maximal arteriolar density, which are the mucosal surfaces of the gastrointestinal tract, renal tract, and the central nervous system. And therefore, these also are the areas of high fibrinolytic activity, and possibly is the reason why which tranexamic acid does help a lot in these mucosal bleeds. Etiology of VWS, we know like VWS can occur in myeloproliferative neoplasms, lymphoproliferative myoplasms. It can also occur in autoimmune diseases. It can be drug induced. Ciprofloxacin and valproic acid are the common drugs which can cause a bleeding phenotype. And other, as a part of if we are a part of a multi-specialty hospital, acquired causes can be congenital heart disease or aortic stenosis, which can have a bleeding phenotype. Pathogenesis of acquired VWD, it goes through these following stages and can go through these following pathways. First, there can be reduced synthesis in hypothyroidism. There can be a consumption in autoimmune disorders. There can be adsorption on platelets as in essential thrombocytosis, or there can be an increased stress as is seen in patients with prosthetic valves, aortic stenosis, or a left ventricular assist device, which could be the possible causes of acquired VWD. So, as we are searching about VWD, this is an old paper from 2002 from Professor Budd. This is a study done over 2 years about the segregation of 1 Willebrand factor testing. So even in this high volume center, only about 25% of the patients were still having one acquired 1 Willebrand disease in as early as 2002. So when they found out what was the etiology, now you can see more or less across the other parameters of myeloproliferative neoplasms, cardiovascular defects versus lymphoproliferative disease. The parameter value are most lowest for the lymphoproliferative neoplasms, which include myeloma. This indicates that there is a much more significant consumption of 1 Willebrand factor in lymphoproliferative diseases, which is possibly due to an acquired paraprotein. This in this very great paper by Professor Tid, How I Treat, published in 2011. This is a simple scatter diagram. The scatter diagram shows the various distribution of tests across two disease spectrums of cardiovascular and lymphoproliferative. And you can see that more or less the lymphoproliferative shows a lot reduced levels of all factors as compared to cardiovascular, which are much more scattered. So normal VWF electrophoresis, even if we may not be experts, however, around 25% will be low molecular weight multimers, 25% will be intermediate molecular, and around 50% will be high molecular. So even though we are not well versed with patterns, but for some difficult things which we learn new, our type 2 thinking comes into play. So type 2 thinking is slow thinking. When we are caught in a disease, it is a multi-system disorder or it is a systemic problem, opposed to system 1, which is a routine problems and we are used to it. So as you can see, this is directly taken from Professor Butt's paper. So these are VWF multimer analysis, which is shown across the low resolution and high resolution. I am myself not very clear with this, but if anyone is interested, they can go through this paper, and she has extremely beautifully explained on how we can go about interpreting this. So the resolution matters, the distribution matters, but for us, for going for exams or knowing that a VWF band will be eluted as a triplet with a thick band and two thin bands above. And the loss of high molecular multimers will be predominantly be there in acquired von Willebrand disease. This is a scoping review on hemostatic management published in 2020 in RPTH. Even after going through literature search for about 20 years, they could identify only 112 patients reported in literature with a male predominance, with IgG predominant kappa type. And as you can see, the M band need not be always a large amount. It was less than 1 gram per deciliter. As per the location of bleeding events, as expected and as thought process, it's a predominantly mucosal type of bleeding, and the VWF activity was severely reduced. The factor VIII levels were not severely affected, and on the multimeric pattern, it was the reduction of high multimolecular patterns which was documented. The clinical outcome was studied for the agents used in the form of DDAVP, the ADH analog, factor replacement therapy, and IVIG. So as goes by the conventional thought process that an IVIG would help by taking away the difficult to treat antibodies, and factor replacement IVIG would help. Whenever we use IVIG, we always, even with ITP, we tell that you get a factor rise in 3 days and you will have a response for around 3 weeks. So similarly is the case with acquired von Willebrand disease also. However, the sustained increase of von Willebrand factor can only be for 6 to 8 hours, and eventually the abnormalities will come back after 21 days. So therefore, some centers have coupled it with plasmapheresis to take away the abnormal antibodies, and therefore in this algorithm for management, for minor bleeding, they have advised ADH analogs followed by IVIG. For major bleeding, they have advised IVIG with other adjuncts, and for perioperative management, IVIG as is used with ITP has been advised. So old is gold, and as Professor Vikram Mathis always says, if you don't see the patient, you will always burn your fingers. So this is something which will always guide us when it comes for diagnosis of VWD, which has to be differentiated between an acquired and congenital defect. So an early onset of bleeding favors congenital VWD. A positive family history favors congenital VWD. Certain predisposing conditions will favor AVWS. Laboratory evaluation showing inhibitors will support AVWS. A genetic evaluation, if possible and positive, suggest congenital VWD. So as with congenital VWD, it is a deficiency and so has to be supplemented. As with acquired VWD, it is an immune disorder and has to be treated like one. So testing pathway in acquired VWD. So has been stressed in this paper, like if you are getting a patient who is presenting to you with first time as a bleeding disorder, then you test this as a bleeding disorder and then you reach towards the diagnosis, whether it is a syndromic diagnosis, and you proceed accordingly to understand the type. However, if you have a patient who is diagnosed with acquired von Willebrand disease or acquired coagulopathy, now who is coming to you for pre-operative fitness, now this is a more difficult situation because it is a known patient, it is an elective procedure, and everything has to be done to minimize blood loss and optimize perioperative blood management. So in such cases, we have to optimize the von Willebrand ratio. We have to use IVIG and therefore move ahead with the pertinent clinical scenario. So principles of therapy. Your intuition is always important and never to ignore your intuition. However, evidence-based management is also necessary. So depending upon the class of disorders which we are treating with, so the category of lymphoproliferative disorders, certain autoimmune diseases like ITP and myeloproliferative neoplasms does belong to us, but wherein we will get referrals from departments like cardiovascular department. At times we do get struck. So in such cases, despite them hurrying for the surgery, we should have a proper evaluation, because most of these surgeries will be on a cardiac bypass machine, wherein patient will be on active anticoagulation and will also have consumptive thrombocytopenia, which will reduce the management. So in such cases, a proper preoperative optimization with a global thrombosis test will be helpful. So acknowledgements, as you know, hematology is a team-based sport. So without the contribution of the patient's trust department of hematopathology and all our departments which help with us, our ID specialists, we really cannot work. And the backbone of the departments, our residents, nursing officers are our true strength. And without them, we cannot do presentations when our patients are sick in BMT. So thank you so much for the opportunity, and thank you. I hand over the mic to Dr.
Thank you so much for that wonderful and detailed elaboration and discussion. A very, very interesting case. So I would request Dr. Dinesh to just say a few words, and then we will move and see if there are any questions.
I just wanted to comment. This guy had come with a saying, because this was a cancer hospital. So he came to me just because he had an abnormal amband. And he never mentioned about, he mentioned that he had two surgeries and there was a bleeding, but there was not such a great extent suspecting that this would be related to this. So how often, I'm just saying, we would have asked for the bleeding symptoms into these kind of cases. And whether there's anything relation of it. Usually we investigate the amband and investigate the other thing, never correlating. His two incidences of bleeding were related to the surgical procedures. So the last one was a major bleed, and that prompted us that something is going wrong. That's how this happened. Any questions from the audience? Did
I think there are some questions. So the first question is, hi, nice case presentation. Thank you for sharing. My question is, and the RGCA group can answer, do you routinely check platelet aggregometry in similar cases?
No. But going back means if someone has a bleeding symptoms, you need to go to the depth of this. What is the cause of the bleeding? This was unusual presentation. He did not mention about this presentation. This is when he had a nasal bleed. That's how we came to know he had a previous episodes of bleeding also. But routinely we don't do it.
Yeah. The second question is 67-year-old female, IgG kappa, M-band of 1.2 with proteinuria. The prothrombin time is elevated with an INR of 1.8, acquired factor 10 deficiency, no CRAP. Is there a role for renal biopsy? How do we proceed with these coagulation parameters? And is there a role for PLEX? And after 2 sessions of PLEX, how to proceed?
What was the age and creatinine?
67. They have not put the creatinine, but they said there is proteinuria.
Bleeding history?
No bleeding history. They just found the prothrombin time, which is prolonged, with the prothrombin time of 20, INR of 1.8.
If there are no indications, we need to rule out the other causes for prolonged PT, maybe the liver or some other cause, vitamin K. We need to rule out the other causes. We need to have a causal relationship of with the amband. We may not treat it if there is no bleeding. We will watch. We see the PT. We see the amband and treat accordingly if there is a worsening.
Yeah, I would agree. I mean, the main worry would be if there's an acquired factor 10, is there underlying amyloid? So you would do the other things. I would not do a renal biopsy because the risk of bleeding will be very high. You look and see if there's anything to suggest on the marrow. You look at the echocardiogram, you do an NT-proBNP, which is an indirect measure of cardiac amyloid. But I would not just treat just for that. And the coagulation parameters per se may not need treatment, because when you actually treat the case, the coagulation parameters should actually improve. So we just have to wait for it to improve. Are there any other questions? If there's any other questions from the audience, please put it online. Either in the chat or question and answers. There's nothing in the chat.
Sir, can I add to this case that has been asked by Dr. Gopinathan?
Yeah,
In
please go ahead.
in case we do rule out the possibility of amyloid, how important is it to rule out inhibitors against acquired factor 10 deficiency? Is it important to prove that? How often is it seen in myeloma?
So what you would actually like to do is to look at the correction of the prothrombin type. I would just look at that. If it's not fully correcting, then of course there are you are saying there are inhibitors. You can see both inhibitors as well as deficiency in myeloma. Now, is that going to make a difference to the way you treat? No.
Okay. Sir, and how often do you do a congruent stain, even in the absence of findings on a bone marrow aspirate biopsy to look for amyloid? Is it done on a routine basis for all myeloma patients?
So we would do a congruent stain on anybody where we put in a suspect of plasma cell dyscrasia. If the clinical suspicion we put it as plasma cell dyscrasia, then the pathologist definitely would do.
And sir, in your experience, how much have you encountered acquired factor 8, acquired hemophilia, factor 8 deficiency in myeloma or in lymphoproliferative disorders?
I mean, we can count cases, it's probably less than 5% where we would find that. Not a very common at all.
So, sir, the algo, as you are suggesting, should be to rule out amyloid and then von Willebrand's and then inhibitors against factors, if at all, in that order, if you suggest?
Because remember, in myeloma, 30% may have associated amyloid. So that is the most common cause for an acquired factor, for a factor 10 deficiency acquired. Now, if that is negative, yes, you look for other things. If the prothrombin time is abnormal, you look for other things. Von Willebrand's usually do not get a PC abnormal. Usually it's the APC that's abnormal.
Sir, and in addition to the case that we presented, though we know that this patient had a bleeding phenotype, myeloma per se is a thrombotic disease, and would you still anticoagulate the patient, or would you wait while the paraproteinemia resolves?
So in a patient who's got a significant history of bleeding, I would not anticoagulate. Okay, because the risk of bleeding is still very high.
And once the paraproteinemia resolves, would you then go
once the paraproteinemia resolves and we find that the coagulation parameters have all settled down? Yes, probably then you can decide whether you want to. But remember, by the time the paraproteinemia and the coagulation disorders settles down, you're probably at least 2 cycles or 3 cycles into treatment. And there, if the disease is already showing a good response, it is usually when you have the active myeloma of a newly diagnosed where the risk of thrombosis is the highest. Once the disease comes down, the risk of thrombosis also comes down.
Okay, sir. Okay, sir. That's very insightful. So then, in your closing remarks, you would recommend that if we have if we have a monoclonal gammopathy of clinical significance, it warrants treatment.
I mean, we would treat. I don't think we can say warrants because it differs from place and there is no. I would say most of them would say there is no specific guidelines for treatment of monoclonal gammopathy of clinical significance. But here, in somebody who's got a bleeding phenotype, definitely I would look at treating because the only way that bleeding phenotype will come down is by treating the paraprotein. And that is the main reason for treatment.
Thank you, sir. Thank you, sir. Thank you for all your answers.
So I think we have done. I think thank you so much to everybody from Rajiv Gandhi. This is a fantastic case actually to present and to discuss, and for the detailed presentation on everything from where you suspect to how you evaluate was really great. And I hope all the people who are listening had a good time listening to this because it was a fantastic case which illustrated a lot of things, not only with regard to malignancy, but also with regard to bleeding disorder. So a combination of both was actually very good. With this, I think we will close and I will hand it over back to Intas. Is Joseph
Thank
around?
you. Thank you,
sir.
Biju. Thank you, Joseph. Thank you, Biju. Thank you, Joseph, for giving us the opportunity. Thank you, my team, for wonderful presentation.
Thank you.
Thank you. Over to you, Intas.
So, thank you so much, sir. As we come to the end of the 5th episode of Blood, the Life Savior, we extend the heartfelt thanks to everyone who joined us for today's session. We are deeply grateful to Rajiv Gandhi Cancer Institute and Research Center, New Delhi, for hosting this insightful episode and for their commitment to academic excellence in hematology. A sincere thank you to Dr. Sarvana Kumar for presenting a clinical intriguing and well-structured case that laid the perfect foundation for discussion. To Dr. Archit, thank you for your in-depth analysis and thoughtful discussion points. And to Dr. Akanksha, we appreciate your skilled moderation, seamlessly guiding the discussion and ensuring a smooth, engaging flow throughout the session. And to Dr. Dinesh Burani, sir, our heartfelt gratitude for your esteemed presence and for concluding the session with such wisdom and clarity. Your guidance brought depth to the discussion and left us with meaningful insight that will surely influence clinical thinking. We also thank our visionary course directors, Dr. Biju George sir and Dr. M. Joseph John sir, for shaping and leading this educational series with such dedication. Your continued mentorship and commitment to hematology education are the pillars to this initiative. And finally, to all our viewers, thank you for your consistent support, your curiosity, and your passion for learning. We look forward to seeing you again in the 6th episode as we continue to uncover the lesser known yet clinical aspects of hematological disorders. Until then, stay inquisitive, stay inspired, and good night from all of us at Blood the Life Savior. Thank you so much, sir. Thank you, Dinesh, sir.
Everyone. Thank you. Thank you, everyone.
Thank you, Biju, sir.
Thank you. Yeah.
Thank you all for the opportunity.
Support.